Hello, I'm Norman Swan. Welcome to this program, Mulling It Over, Cannabis Intervention in Primary Healthcare. Cannabis is the least disapproved of, easiest to obtain and most widely used illicit drug in Australia. It used to, in the old days, be thought safe and probably is less toxic than, say, alcohol, but is associated with psychosis, depression, anxiety, respiratory and other disorders, including dependence. And this program is about equipping ourselves in rural clinical practice to recognise cannabis-related problems and deal with them to minimise harm. We'll examine the latest research and best practice. We'll also look at cannabis use and interventions in Indigenous communities. As usual, there are a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. But before you go there, you've got to meet our panel. Alan Clough is Associate Professor in the School of Public Health, Tropical Medicine and Rehabilitation Science and the School of Indigenous Australian Studies at James Cook University in Queensland. Welcome, Alan.
Thanks, Norman.
Alan is principally recognised in Australia for his significant contribution to research and practice in the field of substance use problems in Indigenous communities. Professor Jan Copeland is the Director of the National Cannabis Prevention and Information Centre. Welcome, Jan.
Evening, Norman.
Jan is a psychologist and has a PhD in community medicine and public health and has made some major contributions to the field of cannabis research before taking on the directorship of the new centre. Faris Samara is a general practitioner in Kempsey in New South Wales and is a staff specialist in the Drug and Alcohol Service in the North Coast Area Health Service in New South Wales. Welcome, Faris.
I know.
Faris is a member of the chapter of addiction medicine and has been so for 5 years and has a special interest also in Indigenous alcohol and drug issues. And last but not least is Tess Finch, who's manager of the Sutherland Cannabis Clinic in the South East Sydney Illawarra Area Health Service. Welcome, Tess.
Thank you, Norman.
Tess has a diploma of drug and alcohol and has worked as a drug counsellor for 6 years. So welcome to you all. Now, what we thought we'd do tonight is run case studies and talk about the issues as we go through what we think might be typical case studies. If they're not meeting your needs and there are things that you want to know that we're not meeting in the case studies, why don't you give us a call or fax us and we'll address those and we'll address that. If you give us a call, we'll bring you into the discussion and you can join in with us. So let's start with Ben. Ben's a 20-year-old man who, in the course of a visit to his general practitioner, that's Faris, with a cough and a cold, states that he's about to join the Australian Defence Force and he needs to take a routine medical examination. But he fesses up that he's a bit scared of the drug testing, which is part of that job assessment, because it might show he's positive for cannabis. When Faris asks, he says he only smokes cannabis occasionally, maybe once or twice a month, and the last time was about 2 weeks ago. You're a patient, Dr. Samara?
Yes, well, Ben is obviously very worried, with good reason, because he might not get the job. It's his whole future. The amount he's smoking once or twice a month doesn't seem to be excessive. Last time he smoked was 2 weeks ago. So very likely he will get a negative urine drug screen if we did one. I would perform one for him. To start with, probably I'll do it in a confidential way. It will not be just between him and I. But I will use this occasion to opportunistically have a talk to him about cannabis and its effects and its possible problems that it comes with.
Tess, a bit harmless, isn't it? A couple of times a month?
Well, I think the issue is that Ben has started smoking a couple of times a month and as Faris said, he does need some information on cannabis and the dangers and he needs to monitor his use and to know how to monitor his use so that if it becomes problematic, he will recognise it.
So what are the risks at that sort of level of consumption?
The risks are that he might start to enjoy that feeling more and associate with people who are smoking cannabis more regularly, so it could increase his cannabis use. Also that he might
start keeping bad company.
He might start keeping bad company, yes. He might also start to reach out for cannabis when he feels life is difficult and use it instead of facing his problems, and his problem-solving skills will actually decrease.
So we pluck this out of thin air, Jan, or is this a typical story?
No, Ben is a quintessential, typical Australian cannabis user. I understand we have a graphic here which shows the findings of the most recent National Household Survey. And we see there that now, as the 60s and 70s happy cannabis users are aging. The peak rates of ever use are now 30 to 39. However, for recent
So kids
use,
aren't taking it up?
No, and our next slide will show that the good news story, if you like, in terms of the very significant reductions in cannabis use that we're seeing in 14 to 19-year-olds and the older age group up to 29. So this is terrific. However, what we're seeing, those that are stuck in cannabis use are showing more problems. There's higher rates of daily use and higher rates of people expressing difficulty in controlling their use.
Different pattern in Aboriginal communities.
It is that that shift in the age distribution hasn't really happened, to my knowledge, in the remote Indigenous communities where I've done surveys. There's still plenty of young users in the 16 to 19 years bracket, and also in the 20 to 29.
So it hasn't declined?
Hasn't really declined.
In fact, it's gone up a little bit, hasn't it, Jan?
Yes, what we don't have great national data, but what we do have indicates that while we've got a 13% reduction overall in the general community since the mid to late 90s, we've got at least a 5% increase in Indigenous communities, and I know in the communities that Alan's been researching in, extremely high rates of daily use amongst this younger age group, which is absolutely concerning, given what we know about the risks.
And of course, Alan, the earlier you use, the worse the outcome.
That's right, yeah.
So, I mean, 14, 12, 13, 14 is what sometimes you see.
Yes, particularly in Indigenous communities, less so in the general community. But what we're learning more about brain development, and from epidemiological studies, that use before the age of 16 is absolutely the red flag for later problems in terms of mental health and dependence.
And other uses.
The youngest stage of first use I've seen in Indigenous communities is 10 years old.
And you've seen it even younger?
I've noticed that, yes, a couple of times younger than that in the town I live in.
So why the change, Jan? What's gone on in non-Indigenous communities to just not cool to smoke cannabis, or what?
Well, that's what we think. We've just in the last probably 5 years had some good public health campaigns around cannabis. We've had better and longer campaigns around tobacco, and we think that part of the smoking is uncool and dirty and messy message is rubbing off to those users who were possibly never going to experience significant problems with cannabis. They were recreational and experimental users.
So they switched to other drugs, the kids?
I think so. Yes, I think, well, at least in rural areas, it might be different in big cities, but we have a fair bit of people who use speed. I've got more and more people presenting with amphetamine use, and alcohol, of course, stays the same, but the problem in country areas is the mixing of these drugs.
So what does the household survey show, Jan?
The household survey actually shows that alcohol and amphetamine use has dropped overall, but I'm sure in some rural communities where there's issues about availability and things
So
like
despite
that.
the moral panic about alcohol, it's dropped too? Similar picture.
Yeah, and we're seeing the same thing with males dropping off at a more rapid rate than females. So we're seeing a convergence in the rates of use, particularly in those young age groups. But what we are seeing an increase in is ecstasy.
And we don't know why.
No, except perhaps has a reputation of being a cleaner drug.
It's more fun drug. I think. The reputation of cannabis as being a stupid drug. It's a dopey drug, makes you tired and not with it. Young people want to go out and dance and rage all night and be able to keep doing that, and they enjoy it more.
But coming down, they also use cannabis
of course,
for that.
Of course.
So how does cannabis rate with other drugs, Tess?
Well, cannabis has been thought of as a soft drug, but working in a cannabis clinic where people are accessing treatment for it, we find that people have a lot of problems from regular cannabis use. 75% of the people who attend our clinic in particular use every day, and it is impacting on most areas of their life, their social functioning, their workplace, their relationship in the family, and financially. So it's not the soft drug that it was once thought of.
So let's go back to Ben. What are you actually going to recommend for him?
I'd recommend for him to give it up, especially if he wants to join the Defence Force. He just can't do it at all, even once every 2 months, twice a month. But I don't know, other than that, just tell him to watch mixing it with alcohol, driving, the legal implications of it. But again, apart from all these things, if he smokes twice a month and he's not at the Defence Force and he's careful not to be caught by the police, there is no direct, I don't believe there is a direct health or implication for it, because he would join the majority of smokers who smoke occasionally.
And as you say, Alan, we're looking at a very different pattern of use in Indigenous communities.
It's quite different. We have high rates of very regular use there, with up to 60% of the 13 to 36 years age groups in some of the communities where I've done surveys using it on at least a weekly basis.
Jan, what do we know are the predictors of cannabis use?
Well, we've talked about the obvious ones of being a male in the 20 to 29 age group. In the terms of occupational categories, we know that people in trades and who work outdoors are more likely to be cannabis users.
Really?
Yes, I think it's more opportunity to use in a less supervised and perhaps fairly routine and mundane work for some people in trades. But the group that we're most concerned about, apart from Indigenous people, is those with mental health problems. They have higher levels of cannabis and tobacco use.
So which way does it go? Because there's been some research which suggests that if you have depression and anxiety as a teenager, that predicts drug use. And then some people say, well, it's the drug use that causes the mental health problems.
Well, I think some of it is an association. We're not that clear about causality. Although now we have good longitudinal studies that have followed people from birth, and typically they start using cannabis before they start reporting significant mental health problems.
So it looks as if the drug use may come first in some instances.
Yes, more typically.
Let's go on to our next case study, who's Owen. He's a 23-year-old Indigenous man with a wife, 2 kids, living in a remote community. And he's got a chance of getting a job with a mining company doing some land rehabilitation. And the problem is, when he's gone for a job, he's tested positive several times on a saliva test for the job with the company. He really finds it a struggle to give up and give up smoking. He and his family share a single room in a crowded house, and most of the other people around him smoke cannabis frequently, and he's finding it tough to give it up, but he's desperate for this job. Is this a real story?
It's a real story, Norman. It's got a positive outcome, though. The guy actually got the job after a while. He succeeded in the end.
Very obviously a tolerant company. They were willing to give him a second go.
Very supportive company that were prepared to give him many chances to pass the drug testing regimes. But I interviewed this man back in 2001 when he was a cannabis user. I believe he started using it about the age of 14. He'd been abstinent, he told me, for about 12 months prior to applying for the position, but living in such circumstances where he has little control over many aspects of his life. He's probably suffering the peer pressure to join in with his family and consume perhaps on the weekends, and then failing the tests on Monday when he turns up for work.
Common story from your point of view in a country town?
Very similar. Aboriginal people have a higher rate of unemployment, lower socio-economic conditions, crowded housing, so very, very high rates of cannabis use, and in a binging fashion too. It seems to have taken over from alcohol in the previous generations. Very early initiation into cannabis use, and very, very common, often in primary school age. But yes, similar situation we have. It's quite common. It's a real problem, especially the early use, because we're worried about the brain development, the frontal lobe development, which doesn't really mature till. So
what help 20s. Did this man get?
He got a lot of help from the mining company, but also he had the support of his family. His own determination saw him through in the end.
So it's like most drug use, most people just give up.
He gave up. He wanted to change his lifestyle. He saw the benefits of doing that, and not only getting the job got him the position and the money, but it got him alternative accommodation so that he could maintain the change in his lifestyle.
So does that reflect it across the board, Jan, that most people who want to give up just do it?
Yes, that's the most common story of what we call self-managed change, that in common with other drugs, particularly the illicits, people give up when they have good enough reasons to give up. They get married, they have the job that they really want, but particularly having a family is often a key turning point where people have enough reasons to make that change. The costs are starting to outweigh the benefits.
So are there proven interventions to help people get off cannabis?
In terms of psychosocial interventions, yes, the cognitive behaviour therapy has a very strong evidence base now. But of course, addiction...
let's not just glance over that. What is the cognitive behavioural therapy focused on?
It's focused on helping people change the way they think about cannabis and how they respond to those thoughts. I can't be creative unless I use cannabis. I wouldn't be able to relax. I wouldn't be able to make music. Whatever it is that they see as the positive expectancies about cannabis, I can't relax in any other way. So it's helping people move beyond that catastrophizing. It would be the worst thing in the world if I had to stop. I couldn't get through withdrawal. I'd have nothing to do. Helping them address the way they're thinking about their cannabis use and simple things. Well, I say simple, of course they're not simple to the individual, but identifying high-risk situations, helping them do behavioural things like bury the bong, rearrange where they typically smoke cannabis, keeping away from keeping away from their cannabis using friends.
And I think it's very important to separate when you're working with people in treatment their behaviour from the personality, because if they've been using for a long time, they become entwined and they can't identify as a self. Yes. So to categorise cannabis use as a behaviour and then look at the positive personality traits of the person can be really helpful to them.
So what happens, I mean, for example, you wouldn't find many psychotherapists in Aboriginal communities, would you?
No, these kinds of services that we just talked about there are scarce, and if they are on the ground, they're possibly delivered by clinicians who have other priorities in a busy rural or remote clinic.
It's likely that somebody like this is also heavily dependent on tobacco. What's the story here between tobacco and cannabis? And does treating one help the other?
Most people mix the two drugs. The majority of cannabis smokers, I think, is it
90%,
smoke tobacco together with the alcohol, with the cannabis. So when we want to treat the cannabis, we will have to also treat the tobacco, which makes it doubly difficult. But
and that's true for Indigenous
just as important.
Yeah. But we don't have good evidence about how best to treat that, whether nicotine replacement therapy, for example, at the same time seems to make sense, but we don't have
eases
evidence.
the pathway. Now, given that we're talking about culturally determined treatments often in this situation with Indigenous communities, does cognitive behavioural therapy work with Indigenous people?
Well, we have no idea. This is one of the areas that have received absolutely no research attention, but I don't think there's any prima facie reason to suggest why not, except I think we need to move it up a notch to include family and community much more broadly than we usually would. I think particularly to identify people that aren't using in the community that might be safe people for these for the individual to move into that extended social network that might be a little bit safer for them. I imagine Alan would have.
I think intervention strategies in the kinds of remote communities that I've worked in, and these are discrete, isolated places with populations of perhaps 2,000 or 3,000 people maximum. The kind of intervention strategies that are needed there at the moment with cannabis use endemic have to be population-based. They've got to be provided at the community level, ideally with some sort of collateral supply control strategies to break the circuit, and then there might be some possibilities for one-on-one treatments.
Are there different patterns of cannabis use around the country in terms of Aboriginal and Torres Strait Islander communities?
We don't really have that systematic data. The work I've done has been primarily concentrated in the Eastern Arnhem Land, in the top end of the Northern Territory. And in those communities I surveyed in detail 200 or 300 participants in a number of communities. And just recently I've toured through most of the communities in Torres Strait and Cape York, interviewing some key people and seeking their views about the issues relating to cannabis. And there are some familiar echoes between Cape York, Torres Strait and the information.
Such as?
The kinds of issues people talk about are frustration with the trafficking and the huge financial impacts that it makes in these communities, the acute psychotic episodes that are clearly connected with cannabis misuse, and the heavy financial burdens, up to, I estimated in the Northern Territory, up to $1 out of every $6 in a community's bank account, if you like, was being relocated into the cannabis trade, quite apart from the more subtle mental health effects.
You would see that a lot, Tess, wouldn't you, even in the non-Aboriginal community?
Yes, we do see a lot of mental health effects. We actually collect data in the clinic, and we find that people who come into the clinic have a higher rate of symptoms of anxiety and depression than has been previously diagnosed. So, and that could be secondary to their cannabis use, or that could be an underlying mental illness that needs addressing.
What have you done? What's your practice with people from Indigenous communities?
In the Aboriginal Medical Service where I work, in a large rural centre, we've done things more on a cultural community basis. We've taken
so what Alan's talking about?
Similar. We've done things with the sports, for example. We've taken groups of young men in their early 20s, about 20 of them, and done weekly or second weekly aerobics classes, swimming.
So community development, that sort of thing.
And arts therapy. We've taken families of cannabis users and they painted pictures and did
Sounds
artwork.
nice, but does it actually work? Is it a useful spend
Look,
of time?
it's very difficult to evaluate these things. We just keep doing them. We've got ongoing programs. We do what we can.
What about training Aboriginal health workers in cognitive behavioural therapy?
That would be great. Talking of which, there's been some work done in alcohol, cognitive behaviour therapy for Aboriginal people, and it's been modified, culturally modified for Aboriginal people with a lot of pictorial methods and so on. And that, I believe, Kate Cunningrave has been done. Yeah. So whether things like that could be adapted for cannabis, I'm sure it can. It's just we need the effort and the resources.
I agree with Faraz there. I think we need those kinds of community development activities at large. The question of evaluating them, though, is enormously challenging because they're very hard to control or direct, because community development always takes on a life of its own. But I'm confident that those sorts of strategies in the kinds of communities I've worked in have an impact.
And I think they do, whether you're doing individual counselling or talking about communities, one of the prime objectives is to get people to engage in healthy activities rather than the unhealthy activities that they have been participating in.
So for GPs watching, this is about engaging the team around you and the resources, whatever it happens to be available in your area.
Yes, yeah. And
Very
whatever
much so.
the person is interested in doing, if you're working with individuals, they have different interests and they will do best at being directed towards those interests.
And Jan, the predictors here are about poverty and deprivation.
Yes, absolutely. The social determinants are a major issue. However, we're seeing in the Indigenous work that Alan's done, and also in the wider community, that a predictor of managing to get control over cannabis use is being involved in vocational activities and employment in particular.
Housing.
So things that fix up the community help to fix up the drug use.
Exactly.
Nick is a 17-year-old boy brought in to see you, Faraz, by his mother. She tells you that he stays up late, he often doesn't get to school at all, he's moody, he's anxious in the mornings. When he does get to school, he has arguments with his teacher. Needless to say, his school performance is dropping off, particularly in the last 6 months. Not been eating much, and he seems to be acting quite strangely, she says, and he doesn't talk much, keeps to himself. What do you think?
It's a real worry. This boy, he's in that difficult age group. The other difficulty is that his mother brought him in, so I'm not sure.
He doesn't want to be there.
No, he's probably coerced. I could tell that from his body language. So the first thing I do is ask the mother to leave the room, unless he insists on having her there. But I think he was quite relieved when I asked her to leave the room, and I had a chat to him just together. And first of all, I would need to gain his confidence and trust that anything he would tell me would be confidential, and that I'm here to help him, not to judge him, not to dob on him. Yes, I'll assure him that I'm not a policeman or a teacher or a parent. I'm a doctor, and that it's all confidential. And if I broke the confidentiality, I'd be breaking the law. So having done that, hopefully he would open up.
So a proportion of kids will take that on board and respond?
Definitely, yes. 17-year-old, I'm sure that he would do it. And legally, confidentiality is assured at that age, even from 14 up almost, yes. So I'll have a good chat to him and see how his private life is going, what his interests are, why is he having trouble at school and in his appetite, not sleeping, acting strangely. I'll have to put it in his own language.
So give me an example of the script.
Okay, I'll say to him, how's it going at school? Do you spend any time with your friends? Do you have any friends? Do you have a girlfriend? Do you go out?
And what are you listening for?
People? I'm listening to what a teenager would say. I'm hoping that he would tell me. I'm suspecting that he's abusing a substance, unless we're looking at a mental illness such as schizophrenia, which is at that age.
Although he could still be just a normal teenager.
It sounds like it's getting a little bit worse. I don't know. I might not be able to do much the first time, and I hope that he comes again, assess him again. But it sounds like I could probably get some information of him. And if he did tell me that he's using cannabis, it would be
So just tell me how you broach that subject with a 17-year-old.
I'll just say, do you spend a lot of time by yourself, and what do you do on your own? Do you watch TV a lot? Do you like to drink a lot of alcohol when you go out? I start with alcohol because it's sort of more acceptable, but then I ask about dope. I'll just call it dope. And how do you smoke a lot? Do you smoke any dope? Do you smoke cigarettes? And then go on to cannabis. He would tell me. I'm sort of confident that I would be able to get it out of him, hopefully.
And for the naive person who might not know exactly what's going on here, just give us the technology here of smoking dope. Currently,
most likely.
What's the patois that one needs to have?
I'll ask him about bongs and cones. That's most likely the way he would take it in. Most people these days smoke.
So in the old days, it was
used to be the joint.
Yes.
In paper rolled. Now they smoke it in bongs, and that's proving to be more harmful. It's a water pipe made up of either $300 worth of ceramic, nice one, or an empty plastic drink bottle, OJ they call it.
And they put cones in that. What's a cone?
A cone is it's a brass metal piece that sits on top of the plastic tubing, and they stuff it with usually tobacco and cannabis. They mull it, that's hence the name of our program. And they stuff it in and they smoke it. So it's an individual amount of smoke, and it's inhaled very deeply, and it's very hot, goes straight into the lungs. It's got a lot
if he said, yeah, smoke a bit, how would you assess how much?
I say to him a bit might be quite a lot to someone else, but I'd say, how many times do you sit to smoke? How many sessions a day do you have? And this boy would probably have, I'm guessing, a few before school and a few after school. So he would have had 4 or 5 sessions a day, and then I ask, how many cones per session would you have? And he'd tell me 6, 7, 8 cones. So we're looking at anything between 30 and 40 cones a day, which is quite a lot of cannabis taken in. The other way to ask, he might not be able to tell me that in this detail. I'll ask him how much it costs him. And he'd be buying it in Buddha sticks. They call them a stick, wrapped in aluminum foil. And that costs between $20 and $30, depends where you are.
And how many cones would you get out of a Buddha stick?
Wow, probably 10 to 20, but many kids smoke 1 or 2 sticks a day, so they're spending a lot of money when you think about their income.
Do you ever ask where he's getting the money from?
I avoid that question. No, I don't ask them that. I do worry about it, but I try not to.
Because that's part of getting close to the risky side of the conversation. You're focused on the
Yes, I want him to trust me, to tell me what I want to know, and try to move on from here.
So most people who use drugs, Jan, enjoy it. They quite like the drug, don't they?
Well, certainly people aren't stupid. They initially give as a reason that they want to enjoy themselves and relax, or just to try it and have fun. But typically that reason is lost as people progress and develop dependence, and soon they're smoking just to feel normal, because they're going through early stages of withdrawal and are actually smoking for withdrawal relief.
Do you agree, Tess?
Yes, and sometimes people who have moved to a dependence, they know that they're feeling anxious, irritable. They might be feeling very low mood when they don't have any cannabis. Like Jan said, when they have some cannabis, that relieves all those symptoms, and so they just think that they're doing it because they like it.
The problem with a regular smoker, though, if they smoke regularly enough, like this boy, if he kept doing it for another year or two, all it takes them is 4 or 5 hours since the last smoke to start getting into withdrawals. Maybe overnight they sleep and they wake up in the morning, they're already in withdrawals.
So give us the symptoms of withdrawal then, Tess.
The symptoms include feeling irritable and anxious, having a low mood, perhaps nausea, sleeplessness is a very common symptom, feeling quite restless. Sometimes people might sweat, do a lot of sweating, particularly when they're sleeping.
Aggression.
Depression, yeah.
So these are questions you might ask about how he's feeling in the morning, just to get a sense of him. I mean, are there tools available to assess how dependent he might be?
Yes, we have on our website at nicpic.org.au some assessment tools there, including the Severity of Dependence Scale, which is a lovely 5-item, very quick scale, which correlates very well to a full DSM-4 diagnosis. And it focuses more on people's concerns about their cannabis use, and so it resonates well with the user rather than being in quite technical language. So that's a very accessible instrument for people.
Now, when I read out that case study, a lot of people watching would have said, this might be first episode psychosis. How would you go about assessing that?
It can be, and this is the concern, it can be aggravated by the cannabis use, but it can be also just psychosis. But although the symptoms don't seem to be yet severe enough to diagnose psychosis.
But he's at risk of it, isn't he, Tess?
Definitely.
Well, he's at risk of it if there perhaps is a genetic predisposition to some type of mental health issue in the family history.
I thought it was clear, Jan, from the epidemiology around the world, that there is now accepted a causal relationship between cannabis use and schizophrenia in the general population, where you've got high cannabis use like Brixton in South London, you've got high rates of schizophrenia. Yes,
although the Brixton situation is complicated by they have a high migration rate as well, which is also a very significant predictor of schizophrenia. But I agree, the evidence is certainly shifting in that direction. Recent meta-analysis have shown that even one episode of cannabis use increases the risk at a population level of about 40%. But when we're starting to talk about people like this young man who are using at an early age and using heavily, their rates of full-blown schizophrenia are at least double, and it's certainly a dose-dependent relationship. And in terms of psychosis, the likelihood is even higher that they'll develop psychotic symptoms at something like 5 times the rate with this sort of a history.
And you're talking about brain changes in this age group, aren't you? Permanent brain changes that you can get.
Well, that's certainly hypothesised. There's been some brain imaging work that's come out fairly recently, which was certainly with very high-level cannabis users over a long period of time, but it's now showing structural changes in the amygdala and hippocampus, which are very concerning, and there's some similar work being seen in animal models as well.
I think it's important too, you know, when we're talking about young people who are diagnosed with a psychotic episode, it's important to remember that it does come out around that age of adolescence, and those young adolescents who do have psychosis tend to use more and more, so they get trapped into cannabis use very easily.
And I think we need to be alert too that once they've had that diagnosis or that experience, that cannabis use very clearly exacerbates the symptoms and makes the course much worse.
Must be bloody scary.
I've seen cases like this in notes in remote clinics that have progressed to serious things like suicide attempts and completed suicide. So I think this guy's probably lucky that he's gone to a clinician.
And the withdrawal can make you quite aggro, can't it, Tess?
Yes, we often hear of clients who become very aggressive when they're withdrawing from cannabis and even inflict physical violence. It can be a problem for families, not only for partners but also for parents. If the young person is living in the parent's home, you know, they can become quite violent, punch holes in walls, attack people.
So what sort of questions would you ask young Nick here to see whether or not there might be delusional behaviour going on?
The usual questions of has he heard any voices that weren't actually there? Was he given any commands that were unusual, that are new to him? Did he see things that do not exist? Does he have any thoughts of self-harm, thoughts of harming others? But the usual questions of delusions, hallucinations, auditory and visual.
We've got some questions here. A question from a general practitioner on the north coast of New South Wales. Is there any relationship between smoking cannabis and smoking wormwood cigarettes?
Not that I'm aware of.
No.
I've never even heard of wormwood cigarettes.
No.
So,
But I guess the kind of people that smoke cannabis would be the kind of people who would try something else.
like wormwood cigarettes.
They're not the Indonesian nice smelling
No, they're
cigarettes.
closed.
No.
They're made of
Question from a
clothes.
general practitioner in Queensland. Is there a link between infertility and cannabis use?
There is some early evidence of that link. It's been shown to affect testosterone levels and sperm motility in males, and also to affect the menstrual cycle with females. It also, and once they get past the infertility in terms of reproduction more generally, it does cross the placenta and it is excreted in breast milk.
General practitioner from South Australia asks, is there a link between impotence, therefore, and cannabis use? And can that be used as a deterrent?
Well, related to lowered levels of testosterone, that may well be affected.
I think even more simply, it's the anxiety and the depression that a person, a man, would have in this case.
And if you're part of that sort of aging baby boomer cannabis user, it might be the tobacco that's causing
Well,
it.
with males, of course, you can also use gynecomastia, which is similar to alcohol, has been shown with cannabis.
Right.
No one wants that either.
Okay, yes, absolutely. What messages, this comes from a general practitioner in Country Victoria, what messages do you use for regular amphetamine users who use cannabis to come down after a 12-hour bender?
Mixing the two together is the worst thing they can do. I was going to mention amphetamine when we were talking about delusions and psychotic episodes and so on. That's probably more likely to happen if they mixed it, but using cannabis to come down is definitely not the right thing, because cannabis doesn't quite relax you, doesn't take away that anxiety that the amphetamine would give you, nor does it take away the depression that you would feel when you come down.
So,
And it may make anxiety and paranoia worse.
Even worse.
So Tess, you've got the 17-year-old, so Faris has referred him to you. He's a heavy user. He doesn't really want to be there, but Faris sort of got him over the line, but he's really resentful. How are you going to look after him?
I'm going to provide him with psychoeducation around cannabis, but at his own pace. I don't think you can rush youth into things that they don't want to be involved in. So my priority at the moment would be to keep communication lines open with him. Even if I had to say, look, you know, I would acknowledge that he might not want to be there, but we need to do this to keep your mum happy at the moment. I would also, if the opportunity, depending on the setting, presented itself, try to engage his mother in some counselling separate to him, because at 17 the family will play a very big role in sort of directing that child back towards positive activities and a strong family environment. Teenagers are very influenced by their peers, but the family influence is longer and will last longer and is stronger in the long run.
So you do some family therapy?
No, I wouldn't do family therapy. That's not my area. If I thought it would help, I would perhaps refer them to family therapy. But I would definitely work behind the scenes with the mother if I got the opportunity to try to help increase his self-esteem and his confidence.
But don't families need help? I mean,
I was going to say,
you're only going to treat the kid, not the family.
Definitely. A session with me, with the mother, is wonderful. But I'd also refer her to a great organisation called Family Drug Support. They've got a website, easy to find, and they support each other, they give information, they do the things you were saying.
So, I mean, it's like anorexia or other drug use. You've got to have a script to be able to deal with your teenage child.
Yes.
And know how to behave and how not to behave.
And the
Must be like walking on
effects on
eggshells.
the family can be it can be really difficult for families. The parents lose their self-esteem. They don't know what to do about this problem. They're worried for the children. It all can spiral downwards very quickly if the family aren't supported.
I mean, I was chairing a drug conference a couple of weeks ago, and there was some evidence from the UK that if you actually don't treat the person at all, but treat the family, you can get excellent results. So in other words, you just forget about the person with the drug problem, just treat the family, and you start to be able to help the drug problem.
That was part of an intervention that we ran a few years ago called the Adolescent Cannabis Checkup, where we first of all worked with the concerned other, which was typically the parent, and it's called unilateral family therapy, where just coaching people over the telephone in how to approach the person with the cannabis problem is very successful in helping engage them into treatment. And we have a resource on our website which is called Talking with a Young Person About Cannabis, which is freely available, which we used in our intervention, and we found that parents found it very helpful.
It's very clear if you have a couple, for example, one of them is trying to come off cannabis, wants to stop cannabis, to explain to the other partner that these symptoms are going to happen, to be prepared for them, and educate them about the symptoms, and to be patient and to give them time. And I usually tell them, look, this is not John that's doing this, it's a drug coming out of John, something like that.
But sometimes really the person living with the person's got to accept the fact that they're not ready to come off, and you've got to live and get on with it.
That's right.
Which is what that unilateral therapy does as well.
Yes, and we also approach with young people a more motivational. As Tess was saying, we're not here to treat you or to make you do anything. We just want to talk with you about your cannabis use. And that approach really does help engage young people.
So tell me what you say.
We say things such as Tess said, we know you're here to please your parent, and that's terrific. That's a great first step. We'd just tell us about your experiences with cannabis. What are the good things? And people, as we mentioned before, typically have what seemed to them at the time very good reasons for using cannabis. Then we explore, what might be less good things about cannabis. And they do actually come up with things, particularly financial, with young people. And then if they don't see the discrepancies in what they're raising, then we might say, well, okay, you're not ready to think about change, but how would you know when things weren't going well with you for cannabis? And often then they raise things that they've already mentioned, and highlighting discrepancies in those sorts of things are a good technique with young people.
Because I think it works on the principle that every drug user, every dependent person has a part in them, in their subconscious mind, that doesn't want to use that, a part in their mind that they hate about the drug. And our job is to stimulate that part and bring out the negative aspects of their habit to them, and let them verbalize it and say it, and sometimes maybe write it down, bring it back next time, in order to reinforce the willingness to change.
Because otherwise people get defensive and they defend their drug use. No, it's not a problem. And it forces them into that kind of response.
But if they're heavily dependent, you've got to talk them through that a little bit, haven't they? Because they might be scared that it's going to be like heroin and they're going to have to detox in a major way.
Yes, it's always good to talk to them and explain to them the cycle of cannabis use, cannabis dependence, cannabis withdrawal. Help them to be aware of what feelings are associated with that, and ask them, do they identify with any of those feelings or with any of that information? To try, to continue to engage them.
Let's go on to our next case study. Who's Gail? She's 45 years old, single mum, 2 teenage kids, lives in a rural coastal town. In fact, it's your rural coastal town, Faris. She's been smoking cigarettes and cannabis regularly for about 20 years. She's got a productive cough and recurrent respiratory infections. And she comes to you saying that really she's having trouble holding it all together. She's feeling demotivated, she doesn't like going to the shop, she doesn't like doing the things she used to be doing, and she just feels a bit worthless.
She's depressed, isn't she? And at times she's probably anxious, which is the flip side of the coin. Yes, so she's going through mood difficulties, mood disturbances, and most likely related to the cannabis, either caused by the cannabis or aggravated by the cannabis use over 20 years.
So this is classic dual diagnosis territory?
Yes, and it's a classic case, single mother, difficult circumstances.
So what are you going to do for Gail?
She'll need treatment. I will, like we said earlier, explain to her first about the information. So it wouldn't be as difficult for her as...
So she's ready.
before.
She's come looking for help.
She's motivated. She's further on in the cycle of change. She's motivated to change. And we will talk to her about the withdrawal symptoms and help her through the withdrawal period, which can last up to 3 to 6 weeks.
But people say that when you talk about comorbidity, the dual diagnosis story, that if you've got depression, you're not going to get people off their drugs until you treat the depression, and the other way around. So in other words, that you've really got to treat the mental illness. So the question I have for you, Jan, and for you, Tess, is cognitive behavioural therapy enough to lift the lid here, that you're going to treat both at the same time? Or is there a case for a short duration antidepressant? Is there any evidence for that, Jan?
Well, certainly cognitive behaviour therapy started with mental health. It started as a treatment for depression, so a skilled clinician should be able to apply CBT to both conditions.
And does it work through the fog of cannabis if she's a very heavy cannabis user?
Well, if she's intoxicated at the time, that is certainly a problem. It's much easier if people come to treatment not heavily intoxicated anyway. But if that's not working in the first instance, then someone like Faris might be the next port of call.
I believe even if she wasn't intoxicated, even if she'd stopped, she will be so anxious and depressed, she will not be sleeping, she'll be irritable, like we said earlier, that she will find it difficult to engage in cognitive behavior therapy. She won't be able to keep the appointment, let alone sit and concentrate and do the homework and the exercises. So this is where I believe some pharmacotherapy as well as the psychotherapy
but the randomised trials have been very disappointing in this whole area.
That's right, so far. But we've done some work on a medication, anti-anxiety medication that I've been prescribing for the last 7 years. It's also used in South Australia. Short-term, mild treatment for anxiety, sometimes coupled with antidepressive behavior would be good. And here I want to mention that really the only so-called accepted treatment for anxiety here is benzodiazepines, and I would like to discourage all my colleagues here in prescribing benzodiazepines for someone who's trying to stop
smoking. You can create a whole new set of issues.
Yes.
And developing, we're just finishing up some clinical guidelines around cannabis, and we do mention after much debate and angst, that's kind of the line of last resort, but you mentioned peroxazine and other antidepressants. We know they're used quite a lot off-label for cannabis withdrawal and reduction of craving. And
I found that anecdotally very, very useful. People have less symptoms of anxiety. They can sleep better, they can engage better, and they.
And do you have trouble getting them off the antipsychotic?
Very easy. No problems at all. It's only a very, very small dose. We use a quarter of the other dose that's used for a psychotic.
But this is one of the ones that the randomised trials have shown nothing.
No, this peroxazine has not been subject to a trial.
Oh,
not yet. I'm hoping that we will next year. We've done a reverse study, and we're hoping that...
So what's the outcome with someone like Gail if she is motivated?
I think it's very good, and I think that if we can manage to encourage her through whatever means, whether it's through medication or through counselling, to cease her cannabis use, it could be a very short turnaround until the time where she's just so pleased that she's stopped using.
And she's ready for other therapy.
Yeah, and her life, has changed dramatically.
And she's somebody you could have a mental health plan for.
Definitely. This is one way of where a GP can access help from a psychologist who will be spending 12 times an hour and a half with her through the year. A GP can never do that, nor has the skill to do that. Usually.
Not many of them around in Aboriginal communities, if Gail was Aboriginal.
We've interviewed women like Gail, and it's very unlikely she'd come to clinical attention unless she went to the clinic for another reason. And but you can be sure that they're out in those rural and remote places.
So yet again, the resources to actually help people like that with culturally appropriate CBT in Aboriginal communities, Indigenous communities, or Torres Strait Islander communities, is really important. Now we're talking here about 2 teenage kids. Nobody's talking about them.
Yes, I was going to raise...
What's the story?
Well,
are they at risk?
Absolutely. We don't have good studies, unfortunately, on intergenerational issues with cannabis use, but we know that that's what we're seeing now, that there's families that have been using cannabis for 2 and 3 generations, and as the evidence is building about the harms related to cannabis use, particularly in this kind of a pattern, it may well be that for the first time it's being recognised as a problem and attributable to some of the family's difficulties.
We've just got a question here from a psychologist in New South Wales. Is there any evidence to support the proposition that long-term cannabis use results in memory loss?
Yes, certainly memory and learning are one of the aspects of
Is that an
harms.
intoxication phenomenon, or is that a long-term phenomenon when you come off?
What we see is that those memory problems improve with long-term abstinence. So it's a positive message that that is something that does improve over time when people stop.
And sorry, I was slightly distracted when you were talking about the teenagers there. Are there interventions that you need to... What would be the recommendation to deal with these teenage children?
Well, I guess, first of all, the positive role model of their mother stopping cannabis use would, and having much better information to share with them and for it to become a family discussion around cannabis. And look, you know, I thought it was fine when I was a teenager, but this is where it led me.
Do you often see the kids with the parents in this situation?
Yes, sometimes we see the kids with parents. Look, I think I agree with Jan. The most important thing is that the mother turns her life around and becomes a positive role model for those children. And then what we've already spoken about around adolescence applies. So, you know, if they start to engage in smoking cannabis, then she'll need to apply the same strategies and pull them back towards positive, healthy activities.
So what I don't understand yet is, what's the treatment goal? Are we aiming here for controlled use, or are we aiming here for abstinence? What's the story?
Either. It depends on the person, on the stage of addiction they're in. We don't tell them which one they should do. We try to reduce the harm. Initially, we try to control the use, but we hope to set a goal.
There's not a path of great success, controlled use.
No, I agree. It's often more difficult to reduce than to stop altogether, go through the withdrawal and then stay off it.
However, trying to direct a client into a goal that isn't their goal isn't a path for success either. So sometimes it's better to let the client say, you know, my goal is to reduce, and then review it as you go along if you can have some more sessions with that client, and maybe, you know, they often swing towards abstinence.
What's the evidence on goal setting, Jan?
No evidence, unfortunately. We're at such an early stage with cannabis. That's why it's so great that we've got a cannabis centre that we can start looking at some of these issues. But I generally, I think, you know, Tess is right, but the advice should be that cutting down with an aim to quitting should be a short term. They should have a goal of 2 to 3 weeks as a quit date to be cutting down towards, is certainly the recommendation for those who ultimately want to quit.
Because often I find that it's more difficult for them to try to keep cutting down and keep having this mental...
Well, you wouldn't do it with tobacco, and they're addicted to tobacco as well.
Yeah.
So, I mean, they're going to want to go back to the tobacco.
It's impossible with tobacco, you can't.
And so abstinence is the aim with tobacco.
Yeah. I think it needs to be the aim with cannabis too.
And sometimes though people have such a strong relationship with cannabis that they really fear that thought of never using it again. And they really struggle with abstinence for that reason. But as treatment progresses and they start to reduce, then their thoughts around that can change.
We did some follow-up studies after 3 years in some Eastern Island land communities, and in the meantime there'd been some targeted community development activities, youth development activities, and also some stringent supply control strategies implemented. And the results were basically that there were still plenty of willing cannabis users in the population, but what had changed was their access to cannabis and the frequency with which they used it. And it seemed like a lot of those core social problems and community problems and some of the acute psychotic episodes also dropped back in the follow-up.
But it was still around.
It was still around, still plenty of willing users.
Hard to control. Just tell us a little bit quickly about NCPIC.
Yes, it's an innovative response of the governments to community concern about cannabis use. It's a consortium of key mental health, drug and alcohol research and clinicians, criminal justice, so bringing a whole new perspective to the issue of cannabis. And we have three main aims. One is to provide evidence-based information, because that's one of the issues we've identified, that people just don't necessarily have good quality information about cannabis. So we have a lot of resources downloadable on our website. We also aim to train the workforce. We provide free training nationally, and on our website you'll see the types of training from community awareness about what are the harms associated with cannabis, through to how to deliver up to 6 sessions of cognitive behaviour therapy. And we're also developing new interventions. And as a result of that, we now have free interventions available via the post, for example. So if you're a rural GP, you can't provide CBT, your client can access free interventions via the mail, and we also are about to launch an intervention on our website and also through our free national helpline 1800 30 40 50 that people can call just to ask questions about cannabis or now how to access interventions.
And these cannabis clinics, do you work in New South Wales? Are they in any other state?
No, they're only in New South Wales. They're an initiative of the New South Wales Department of Health. They were set up because there was a large number of cannabis users who weren't accessing treatment at the established drug and alcohol services. So it was felt that if separate clinics were set up and marketed to that population, then that would increase the access, and that's exactly what's happened. Around 50% of people who attend the New South Wales cannabis clinics haven't had any treatment prior.
So they're referring themselves, or GPs can refer them?
Yes, yes, or any health professional can refer them as long as the person gives consent. They're free and they...
And you give them evidence-based therapy?
Yes, we do. For around 6 sessions, but very flexible depending on the needs of the person.
And what sort of results are you getting?
At Sutherland, we have around 50 to 53% success rate. That is, people who have met their treatment goal when they finish their treatment.
And how many of these centres are there around?
There's 5 centres across New South Wales, with another one about to open. And the centres on the North Coast, out in the Central West and on the Central Coast have satellite centres at a lot of the community health centres. So if anyone would like to see exactly where those clinics are, they could access that information through the Sutherland Cannabis Clinic website, which you can Google. And
we'll have it on the Rural Health Education Foundation website as well as a link.
Okay.
Fascinating, this discussion. Thank you all very much indeed. What are your take-home messages for those watching? Tess?
I think that the take-home message is that the parents play an important role with young people, as we talked about. I think that's something that hasn't been talked about a lot, so I'd like people to remember that. And also that there are clinics out there for people to access, and GPs to phone if they want information. Yeah.
Maybe in other states in years to come. Faris?
Yes, I want to, my message to my colleagues, the GPs, is that knowing that most people go first to the GP with any problem, that first of all they need to ask the question, assess the drug and alcohol history of the patient, especially these people who we're talking about, familiarize themselves with the withdrawal symptoms, because they're very, very important, and with the treatments of the withdrawal symptoms. Avoid Valium or benzodiazepines, as I mentioned earlier, and know how to refer to NCPIC or to the cannabis clinics or to the psychologist through the mental health plan.
Jen?
I just wanted to reinforce to keep cannabis top of mind if you're a GP or a primary healthcare practitioner, to ask the question, and to know that resources are available through NCPIC, free, nationally, and also through our 1800 30 40 50 number, where you can have referral to all kinds of interventions, and any kind of question about cannabis will be answered.
Alan?
Well, unfortunately, it appears from our consultations and research that cannabis has become endemic in many remote Indigenous communities. And there's clearly a lack of services in particular for individuals, but I think most urgent is the need for multiple component community-based intervention strategies that can build community capacity to raise awareness and to try to support families and other groups in the community.
Because the things that cure communities will help the drug problem as well. Thank you all very much indeed, and I hope you've enjoyed tonight's programme on cannabis in primary health care. If you're interested in obtaining more information about the issues raised, there are a number of resources available on the Rural Health Education Foundation website, rhef.com.au, and there'll be links to the websites we've discussed tonight. Don't forget to complete and send in your evaluation forms, and please register for CPD points by completing the attendance sheet. I'm Norman Swan. Bye for now.